Good morning, one and all. Today's topic of discussion is EEG artifacts and their rectification. Myself, Dr. Manasa, and my moderator is Ramshikar. So we will be discussing today's topic under following headings like introduction, classification of the artifacts, what are physiological artifacts, external or environmental artifacts, and correction of the artifacts. So what is an ideal EEG? Coming to introduction, it reflects purely cerebral activity and negligible extracerebral activity. And it is performed by a qualified EEG technologist who can create an artifact-free recording with a technically adequate recording. Along with that, it requires a cooperative patient in a quiet environment. But practically, ideal EEG is unachievable, and many times the common artifacts cannot be avoided. So how we will achieve an ideal EEG? So first we will go little technical aspects of the EEG to understand the artifacts in particular. So what are the different components in a EEG machine? We know already the electrodes, and there are which are connected over the patient's scalp, and there are lead wires which we connect them into a jack box. So this jack box will be having a various amplifiers. There will be differential amplifiers and there will be an amplifier. So this forms a circuit. So we need a low impedance system. So the impedance between skin and electrodes ideally should be below 5 kilo ohms. So this requires a proper skin preparation, remove the excess oils and application of the conductive paste to achieve this impedance. And we have extra electrodes other than electrodes what we pick, which pick the cerebral activity. That is, there is a ground electrode and a system reference electrode. These two electrodes are used to reduce the noise in the EEG. So the ground electrode, we will connect the body to the ground circuit within the amplifier. So it acts like a noise shield. Usually it is useful in blocking the 60 Hz power line noise which is there due to alternate current. And there is a system reference electrode which serves as a 0 point. So the ground electrode we can put on the body anywhere, usually over the forehead or behind the ear. So there is a system reference electrode which serves as a 0 point against which each electrode records its voltage difference. So in EEG, the ideal EEG is obtained in a Faraday cage. So we want an environment like a Faraday cage so that we will obstruct all the external electromagnetic radiation or whatever to come into our circuit. So now we don't need a Faraday cage because the EEG machines works on a technique called as differential amplification. So the amplifier within the EEG have a differential amplification. That is, it will not it will pick up the difference in the difference in the voltage between 2 points. That is, if there is a terminal 2 and terminal 1, so there are two inputs. That is, one is a common mode signal, the other one is a differential mode signal. So this common mode signal will be common to all the electrodes. The common mode signal is usually the environmental noise which is there present in the all electrodes. All electrodes are exposed to the same environment. So the common mode signal will be similar between 2 points. And there is a differential mode signal, which is usually a cerebral activity which the electrode picks up. So we want a differential mode signal, but we don't want a common mode signal, which might disrupt the signals on the graph. So the ability of an amplifier, the differential amplifier, to pass the differential mode signal and block the common mode signal is described by common mode rejection ratio. This is expressed in the decibels. So this helps in reducing the electrical noise. So for this, you want a reference point also. There are filters within the EEG, like high frequency filter usually set at 70 Hertz and low frequency filter at around 1 Hertz. And there is a notch filter. High frequency filter is also called as a low pass filter, which will filter out the higher frequencies above the 70 Hertz and above. And low frequency filter is otherwise called as a high pass filter, which will filter out the frequencies below it. And there is a notch filter which is at a 50 Hertz. This is usually used to filter out the 50-60 hertz alternate current artifact in the EEG. So for example, if we take it in like FP1, F3, longitudinal bipolar montage, usually we will take FP1, F3 in reference to F3. So FP1 will pick a common mode signal. For example, 60 hertz artifact, which is usually present, power line artifact, which is present over the all electrodes. So FP1 pick the same signal and F3 also pick the same signal. But what is the different signal it is picking from the cerebral activity? There is a minus 10 microvolt signal picked up by FP1. And there is a minus 5 microelectrovolt signal picked up by a F3. So there is a differential mode signal as well as a common mode signal, if we see here. So when this pass through the differential amplifier, this differential amplifier will cancel out the common mode signal and will only reflect the differential signal. That is, it is like a mathematical equation, like FP1, F3 means there is 10 minus of minus 5. So it will be a minus 5 microvolt, which gets amplified and reflects. So in EEG is opposite to the ECG. So whenever there is a negative potential, it gives a positive deflection, and a positive potential will give rise to a negative deflection in case of EEG. This is how we will cancel out most of the noise in the EEG. But still, because we can't achieve the similar impedance among all electrodes, and there might be some errors which might result in the artifact formation in the EEG. So the artifact definition, it is an electrical activity of a non-cerebral origin which is picked by a EEG. So often it is mistaken to be a cerebral electrical activity. So it is important to recognize and remove it. So to avoid the misinterpretation of the EEG. So what are the characteristics of artifact? How to recognize an artifact in a EEG? So activity or a waveform confined to a single channel in a referential montage or a two neighboring channel in a bipolar montage. That means it doesn't have a field. Usually any cerebral potential will have a physiological field. It is maximum at a point of where it is produced, and as there is an increasing distance between the point of production to the electrodes, there will be a fall in the voltage. So maximum at a point which there is a production of the cerebral activity and drop in the voltage with increasing distance. But the artifact will not follow this rule. So there is no physiological field. And they are highly stereotypic and monomorphic pattern. And they are the activity with extreme frequency, like either very high, more than 70 hertz, or a very low, less than 1 hertz. Or they are non-anatomic pattern, and they are atypical with multiple phase reversals, and periodic pattern with a perfect regularity, like an EKG artifact, which presents with a perfect regularity with the EKG. So coming to the classification, the EEG artifacts can be physiologic and non-physiologic. Physiologic are the artifacts which are produced within the body of the patient. So it is either because of eye movement, electromyographic, or glossokinetic because of the tongue movement, or ECG artifact, sweat, and patient movement. All these are artifacts under physiologic artifacts. And there are non-physiologic artifacts either because of the instrument itself, produced from the EEG instrument, or from the environment. So either because of the electrode or the lead wires, which we saw in the first slide, it can be produced there, or at the level of instrument, that is in the jack box or amplifier or a cable wire, or the environment from the outside. That is a 60 hertz artifact which is commonly seen, or a ventilator or others. Internal electrical stimulator is nothing but a pacemaker or DBS within the patient can also cause a artifact on the EEG. Coming to physiological artifact, which are generated by patient's biological activity. Many sources within body acts as a dipole. Electric dipole is a positive charge at one end and a negative charge at another end. So these are produced by eyes, muscles of the head and face, and because of the cardiac activity, glossokinetic, or because of the respiration and galvanic skin response, or nothing but a sweat artifact. So these are the various physiologic artifacts. Eye movement artifacts So the eye movement artifacts can be either because of a horizontal eye movements or a vertical eye movements or because of the electroretinogram. And cardiac artifacts will be either because of ECG, pulse, or a pacemaker or ballistocardiographic artifact. So the muscle artifacts or myogenic artifacts can be lateral rectus spike, frontalis, temporalis artifact, or occipitalis, swallowing, chewing, and photomyogenic artifact. And galvanic skin responses can cause a salt bridge because of and perspiration also. Physiological movement like a head movement or a glossokinetic artifact because of the tongue movement. So coming to the eye movement artifacts, eye acts as a 100 millivolt electrical dipole. So there is a cornea at one end, which is more positive compared to that of the retina. So in a EEG, when a positive charge comes in front of an electrode, it will show a negative deflection. So this we have to keep in mind. And when eye moves, the electrical dipole also moves, resulting in a potential based on the direction of the movement of the eye. So virtually every awake and conscious individual during routine EEG will have this eye movement artifacts, and these eye movement artifacts are picked up in the anterior location, that is over frontopolar electrodes or anterior temporal. In the next. Positive charge will cause downward deflection and a negative charge will cause upward deflection. So usually eye movement artifacts will be symmetrical. There are certain conditions where we might get a asymmetrical eye movement artifacts, like when the electrodes are placed asymmetrically, when the distance between the electrode and the eye is different on the both sides, or a decreased movement of one eye because of any third cranial nerve palsy or a ophthalmoplegia, or absence of one eye, that is a prosthetic eye, or a phthisis bulbi, or destruction of the retina of one eye, or any frontal skull defect in case of post-craniotomy patient can produce a asymmetry in eye artifact. So first, the vertical eye movement artifacts, this is because of the Bell's phenomenon. When we close the eye, there will be upward movement of the cornea. So when the cornea is moving upward, the FP1 electrode is becomes more positive when compared to the F3. So FP1, F3, we will get a downward deflection because it is more positive. And so FP1 and F2 will, when cornea move up, resulting in positivity in FP1 and FP2, which results in the downward deflection relative to F3 and F4. So this will be a slow signal less than 4 Hz corresponding to the mechanical movement of the eyelid. Does not extend beyond the mid-temporal region. This is important to differentiate it from the FIDA, which can extend beyond the mid-temporal region into the posterior regions. So symmetric between two hemispheres. So this is the vertical eye movement artifacts. So when the eye is closed, the cornea will move upward, which causes negative deflection. And when the eye opens, the cornea again moves forward, which will create a positive deflection, upward deflection. So this is a condition where we are getting asymmetric. We are picking up the eye movement artifacts only in the left electrodes, and right is not showing any eye movement artifacts. So this is a case with the right phthisis bulbi, which show the asymmetry of the eye movement artifacts. So when there is a repetitive blink, sometimes the rhythmic blinks can produce ocular artifacts that can mimic delta. So like a FIDA, frontal intermittent rhythmic delta activity. So it is very important to differentiate between the blink artifacts versus FIDA. There is ocular flutter, which is a rapid rhythmic and low amplitude intermittent compared to the blinks. Can cause a alpha range, little more it has a more frequency compared to a rhythmic repetitive eye blinks, can cause even the alpha range frequency in the frontopolar electrode. So this is a repetitive eye blink. So how to identify it as an eye blink artifact is it will not extend beyond the mid-temporal. It is mostly present in the frontopolar electrodes. So FP1, FP2, symmetric in bilaterally. So these are the repetitive eye blinks can sometimes be mistaken to the FIDA activity. This is a ocular flutter or a repetitive eye blink artifact, more frequent than that. It is an ocular flutter. So this is a longitudinal bipolar montage and coming to the common average. So these are picked up only in the frontopolar, the anterior frontopolar electrodes. So this is a further activity which is seen here. So which extends posteriorly beyond.
Sharp face that are admitted with the FP2 channels on the right side. So sharp face admitted. It's like bypassing right in just coming over bilateral quantum regions, more problem from the right side. FIDA is much more monomorphic with the time. How would you differentiate those eye blinks from FIDA?
FIDA, eye blinks are differentiated from the FIDA. Like it will not extend beyond the mid-temporal, and it is rhythmic with the eye blinks.
Right. You can see sometimes that you see that lateral on the left side, you can see those positive reflections.
Positive reflection.
F3 and C3.
Yes, sir.
Left side, left. So artifact effect. The artifact, you can see that the reflections are extending to F3 and F4.
Yes, sir.
So in that situation, how do you distinguish these? This is very straightforward idea. In some situations where you see flutter, like in the previous exam, you can see that sometimes that activity, especially by the fourth or the fifth second, you can see that activity is like polymorphic with big delta. But it is confined to the
frontal polar channels. It is confined to the frontal polar. FIDA is not seen in only frontopolar. It will extend posterior. We can close the eye with the one. We can place a pad on the eye, or we can ask the patient to place the finger on the eye.
They're extremely anxious that how these activities come on. So generally you ask the technologist, or the technologist will automatically place a
cotton pad over
the patient. Thanks. It doesn't stop with that. What is the next thing? They're not sure.
Electrooculogram, we can connect and see the
electrooculogram. What you do for? Where do you place electrooculogram?
over the eye.
Outer
the canthus.
We look for phase reversal.
Phase reversal between FP1 and so to differentiate between the eye blinks and this FIDA, we can place a electrooculogram over the outer canthus, and there will be a phase reversal between the frontopolar and electroocular. Lateral eye movements, horizontal eye movement produces artifacts in the anterior temporal derivations like in F7 and F8 when the eyeball moves to the sides. So for example, if the patient looks towards the right side, so in the right side, there are F8 becomes more positive compared to that of a FP2. So that results in the upward deflection is FP2, F8. So when and there is a downward deflection in the opposite.
That side will have a downward deflection. So when it moves out of phase, so there is a downward deflection on that side. That is when stands there. That's that side of rotation.
So when the patient look towards the right side, there is a out of phase. Like F8 will have a downward deflection, and FP2, F8 will have a upward deflection. So the opposite side will have a phase reversal. Like the F7 will show the phase reversal. So this is the artifact. So here the patient is looking towards the left. So when they are looking towards the left, there is a out of phase on the left, and there is a phase reversal seen on the right side. So the same way, if the patient is looking towards the right, so there will be a phase reversal seen on the left and the out of phase movement on the right side.
What are those sharp transients typically?
So these are lateral rectus spikes, which are seen with the eye movement.
That's produced by the
Sudden eye movement will cause the lateral rectus artifact, which can be seen along with the lateral eye myogenic artifacts from the lateral rectus muscle. So this is an example where we might get a asymmetric horizontal eye movement artifact when there is a right prosthetic eye. This patient had a right prosthetic eye, and we can see only the horizontal eye movements only on the left side.
right. Down on the giant.
This could be frontalis twitch.
That's
What we see in the right channel is a frontalis twitch, which is seen in the frontocortex. So roving lateral eye movements, this occurs during drowsiness. These are of the frequency of 1 Hz and low amplitude, accompanied by the alpha dropout. So these are the slow roving eye movements which are seen during the state of drowsiness, along with the alpha dropout, which can see in the posterior channels. There is horizontal nystagmus, that is a fast movement. These are also seen in F7 or F8. In the side of fast phase of nystagmus, we will see that movement. They mimic the, they are in the shape of the shark fin shape or a sail shape, what we call. There is a steep initial upslope because of the sudden movement of the eye, and a gradual return to the baseline because of the opposite. So these are the shark fin-like artifacts which are seen in the F7, F8 as well as the F7 as well as the F8. So these are the nystagmoid artifacts. Cerebellar disease. Amblyopia. So in patients with amblyopia or occipital gliosis, we can see these nystagmus artifacts. So electroretinographic artifact, this is produced because of the photic stimulation, usually seen at the low frequency. These are also seen in the anterior head electrodes. So this is because of the intermittent photic stimulation, and the retinal cells will get stimulated. So this almost mimics the electroretinogram which we see. The electroretinograph will have a wave, which is a negative deflection, followed by a B wave, which is a prominent positive deflection. So this A wave is because of the photoreceptors, and bipolar cells will cause some positive deflection. So the similar kind of wave is seen in the EEG. So usually see important in when we are measuring recording EEG in patients with the suspected brain death, where we use high sensitivities, and this is very important to avoid the misrecognition of this electroretinograph artifact as a cerebral activity, particularly in a brain death individual. So this is a example of an electroretinograph artifact which is seen in the over the frontopolar region bilaterally. And this is showing initial negative deflection followed by major positive deflections. So how we recognize the differential diagnosis are the photomyogenic artifacts and the bifrontal spikes. So when you cover one eye during the photic stimulation, this will abolish the electroretinograph artifact on that side. But photomyogenic, it will remain bilaterally even if you close one eye. So when we record electroretinograph artifact with the right eye covered, we can see only in the left leads, and there is no artifact present in the right. So it is obscure. So rectification of the eye movement artifacts, we can ask the patient to close his eyes, placing the cotton pad over the eyes or placing fingertips. So the cardiac artifacts, this can be ECG artifacts, pulse artifacts, ballistocardiogram, or the pacemaker artifact. ECG artifact. ECG artifact is an electrical dipole generated because of the cardiac depolarization. This will form a poorly formed QRS complexes which are seen over the EEG. So they are diphasic and it is time locked, rhythmic and time locked with that of the ECG. So these are more prominent when we use the referential montages, particularly when it is a ipsilateral ear montage, and more maximal over the left posterior head region, and commonly seen in the short neck individuals in babies, and can mimic the cerebral sharp waves or the spikes. So this is one ECG artifact which is seen over the posterior head regions, most prominent on the left side. So it is time locked with the ECG and very rhythmic and regular. So this is a referential montage which is showing the ECG artifact along with the ECG, time locked with the ECG. So when we use the ipsilateral ear montage like here, so this will show the increase in the more prominent ECG artifacts. So, but in patients with cardiac arrhythmia, the ECG artifact may be inconsistent, it will be irregular, can be misinterpreted as an epileptiform abnormality or a focal slowing when it is not extrapolated to the ECG. So, this is one of the example where the patient have a frequent VPCs, so which are reflected upon the particularly over the left-sided electrodes, left temporal chain. So which might, if we don't look at the ECG and we look into this, so this might lateralize, maybe looking like a lateralized periodic discharges and may misinterpret like that. It is time locked with the ECG.
This was probably not identified, but the ECG was not written. It is coming too rhythmically.
True rhythmic.
I can see that it's coming very quickly. There is a fixed time interval between them. Almost 3 seconds time interval.
3 seconds. So
you have a careful look at the EKG and see. Similar to the EKG artifacts I use see the visual conversions. These are VPCs.
These are VPCs. So these are VPCs. They are coming rhythmically at every 3 second interval. So it is more rhythmic, and when we see it in a EEG more rhythmic, we have to look into the EKG and then correct it. So correction of the ECG artifact by hyperextension of the neck or using the linked ear montage, which will cancel out the ECG artifact. So this also will work on the principle of differential amplification. Recording the EKG during routine EEG is very essential to enable the recognition of the EKG artifact. So this A1 and A2 we will link, sir. So the ECG artifact will be seen as a similar in bilateral head regions.
Rectification has temporal mobility. What would you prefer using?
No, we will not prefer using linked ear because it will cancel out even the temporal discharges when we move. Contralateral ear. So in patients with temporal lobe epilepsy, we can't use the linked ear montage. So in that cases, we can use a contralateral ear link montage to differentiate it. So pacemaker artifact, these are more generalized. They are high frequency polyphasic potential because of the pacemaker activity. This usually precedes the usual cardiac signal and very shorter duration when compared to the EKG artifacts. So maybe continuous or intermittent depending on the pacemaker type. So this is one of the pacemaker artifact. We can see the pacemaker potential over the EKG, which is forming some transients which are polyphasic and very low duration compared to ECG artifact. Pulse artifact occurs when electrode is overlying a pulsating vessel. So it is more frequently noted over the frontal and temporal regions where the vessels are there. So occurs after a delay of 200 to 300 milliseconds with the ECG QRS complex, because it is a time taken for the pulse wave to reach there. So can be identified by touching the electrode producing it. So you can feel the pulsations. So mostly the pulse artifact at a temporal region can make a trade-off. So we have to carefully observe. So here we can see the pulse artifact, particularly over the T4. The electrode is placed over the artery. So this T4 is causing some activity here. Only present in two channels in the longitudinal bipolar montage. We have to look onto the referential montage. So if we see the referential montage, it is present only in the one channel, and it is time locked with the ECG. Means after the ECG, 200 to 300 milliseconds after the time interval, this is occurring. And when we see the peak to peak time, in this pulse artifact will be equal to the RR interval on the ECG. So we can differentiate it even measuring that. So pulse artifact is corrected by moving or refixing the electrode. Ballistocardiographic artifact, subtle vibrations of the body causes ballistocardiographic artifact in conjunction with the systolic pulse wave and produces a low voltage, sometimes mimicking the rhythmic delta activities. This is seen in the high cardiac output state because of the movement of the head over the pillow. So this can be reduced by the head or neck over adjusting the head or neck over the pillow. So coming to the we don't commonly get. I didn't get the image of that. So in fMRI, there are studies which looked into ballistocardiographic.
So concern, these artifacts are a concern your EEG
EEG
combined EEG. It's an important artifact transmitted as a whole signal.
Whole signal.
That requires motion correction.
These are more.
So you can patient coma as well as brainstem get some benefits. Generally characterized by movement protection. I love the one.
So those are more important in the EEG fMRI studies, where we get to see these artifacts more. So coming to the myogenic artifacts. So these are most common source of the noise in EEG. They are very spiky, but very in a high frequency ranges. And they are produced over the frontalis and temporalis. These are the principal muscles causing the myogenic artifact. Can mimic the paroxysmal fast activity, 50 Hertz artifact from the power supply, or the beta activities. So there are different myogenic artifacts like lateral rectus, superior rectus artifact, and frontalis EMG artifact and temporalis EMG artifact. So the lateral and superior rectus artifact. So lateral rectus artifact will produce because of the rapid horizontal eye movements. There is a contraction of the lateral rectus which causes single motor unit potential, which will be reflected on the EEG. These are seen in the temporal anterior temporal channels like F7 and F8 electrodes. So superior rectus is because of the vertical eye movements, single motor unit potential caused because of the superior rectus contraction. These are best seen over the FP1 and FP2. So these are very low amplitude, which will be followed by the eye movement. Sometimes if we don't carefully see, it might mimic a spike with the after coming slow wave. So this is a superior rectus artifact, which we see only in the frontopolar region, FP1. And these are the lateral rectus artifacts seen in the temporal chains with the horizontal lines. So in this picture, we are seeing superior rectus artifacts over the frontopolar channels. So frontalis myogenic artifacts, these are best seen in the frontal electrodes. So frontalis muscles becomes most involved when there is a forced eye closure, and particularly during the photic stimulation and in an anxious individual also. So these are short duration can occur like a frontalis spike, like an EMG potential or a continuous fast activity. So This is a frontalis myogenic artifact, which is seen in the frontopolar channels alone. So this is mimicking a railroad track appearance because of the multiple motor unit potentials, which have a railroad track appearance. So this is a common average, which is showing isolated frontopolar regions, showing the frontalis myogenic artifact. So this is a beta activity. So the myogenic and beta activity can be differentiated, particularly when the fast activity occurring over the vertex region where there is no muscles. So that should raise the possibility of a other like beta activity or a gamma activity rather than a myogenic response. So there is a photomyogenic response, photic stimulation leading to the EMG artifact, usually over the frontal aspect, anterior scalp muscles. It is time locked with the photic stimulation over the frontal periorbital region bilaterally, also called as a photomyoclonic response. Because of the strobe flash, it occurs, and intermittent photic stimulation, usually at the range of 12 to 18 per second, will trigger the most of the artifact. This could be differentiated from the photoperoxysmal response. These are more common in the frontal chains, but photoperoxysmal response is more seen in the posterior head region. So this is the frontalis muscle. So photomyogenic artifact is a high frequency artifact in the frontal chains alone, but the photoperoxysmal response will have a spike wave activity. It is seen in the posterior head region. Depending on the grade of the, it is more can be can.
Starts off when you put the bottom. You can get generalized responses, which offer outlast the stimulus.
So it can start in the occipital and go into the frontal region, like photoperoxysmal response based on the grade. So temporalis myogenic artifact, this is produced during the chewing movements, produce rhythmic bursts that are maximum in the temporal chain, though they can be diffuse. So tight jaw closure, bruxism, oral automatisms, and orofacial dyskinesias are the various conditions where we see this temporalis myogenic artifact. This is an example of the chewing artifact, which is rhythmically occurring because of the chewing. So when we ask the patient to open the jaw or relax, this artifact will disappear. So the correction is asking the patient to relax, massaging the muscle groups and opening the mouth relaxes the jaw, and temporalis artifact will disappear. So you can use the high frequency filter also to filter out this high frequency artifacts, myogenic artifact. So here when asked patient to open mouth, this temporalis artifact is disappearing. So when we set the channel high frequency filter to 15 as here 15 hertz, so this all muscle artifacts get filtered out. So we will be seeing no muscle artifact here. So high frequency filter can be used, filter out. Glossokinetic. It can alter the EEG aliasing of the signals.
So high frequency filter is that the alias. Basically, that will ensure that so keep the anti-aliasing filter on, or you reduce the frequency of the anti-aliasing filter.
The waveforms will get it.
Waveforms will.
So when we will usually not reduce the high frequency filter because it is a anti-aliasing filter, which if we reduce it, most of the required physiological potentials which we want to see on EEG can be filtered out. So we don't use that. So glossokinetic artifact, the tongue tip is electronegative and base is the positive. So tongue also acts as a dipole. So this produces a broad electric field. So that drops from the frontal to occipital region. Seen in the tongue tremor, and a nursing infant can also result in a rhythmic discharge. So glossokinetic artifact differential is a FIRDA, and it is easily reproducible by saying la la la, like producing the sounds, and it will have a superimposed muscle artifact. So these are the ways we can differentiate. This is a reproducible artifact. So when the patient is telling la la la, so we will see that glossokinetic artifact, which is more seen in the frontal, which have a broad field, frontocentral field. So can extend posteriorly also. Mostly confined to the frontocentral region. So sweat artifact, sodium chloride and lactic acid from the sweat reacts with the electrode metal, which alters the resistance. Impedance of the electrode will be changing continuously, and there will be loosening of the electrode. This will cause a baseline deflection, which is low amplitude undulating wave, what we see, greater than 2 seconds duration. So we can remove the sweat artifact by increasing the low frequency filter. Drying the scalp, reapplying the electrode, and cooling the patient with the fan. So this is the sweat artifact. This is a low frequency artifact of 2 hertz frequency. So like a undulating waves we see. So when we increase the, usually low frequency filter is set at 1 hertz. If we increase it to 2 hertz, this will cancel out the sweat artifact. So it is this low frequency filter is determined by a time constant. So the time constant is a time required for any square wave deflection on the EEG to decline by 63% from the peak. So this is inversely related. When there is a shorter time constant, the low frequency filter frequency will increase. So we are shortening the time constant by increasing the setting of the low frequency filter, and the sweat artifacts become attenuated. So movement artifact occurs because of the voluntary or involuntary movements of the patient, which will cause the electrode displacement, which can result in a movement artifact. So this is one movement artifact which produces a high amplitude waves because of the movement of the patient. So this is one of the movement artifact seen in a tremor patient, which is mimicking a ictal rhythm. So when you see there is rhythmic activity seen over the mostly over the posterior head region bilaterally because of the head tremors in a patient. Unless we see the video and correlate it, most of the times because there is evolution also which is seen, which can be mistaken for a ictal rhythm. So here, when we see a common average, there is a out of phase seen in this case of head tremor. Occipital channels, anti-temporoparietal regions, mimicking the same.
And there is, you see the reflection between the D4, D6, and you can see an
out of phase movement.
So theoretically
hard to distinguish unless we.
Evolution usually happens in terms of it's change in frequency, which is not there.
So in
post event slowing. So we have to look at after some pages whether there is any focal slowing that we get papers. Otherwise, you have just time block this with the
movement
just
EMG.
video of the patient.
So we can time lock with the video of the patient, or we can extend and see the after slowing in the EEG. Or in this patient, there is no much increase in the frequency. We notice the frequency is similar, and there is a out of phase reaction seen in the posterior. Out of phase deflection seen in the posterior. Non-physiological artifacts are electrode artifacts or the instrumental artifacts from the instrument, or environmental artifact from the outside the environment. So the most commonly what we see are the equipment related artifact. This can occur during along the pathway of the equipment. So it can occur at the level of electrodes, which we saw in the first slide, electrodes and cables and wires which get connected to the jack box or an amplifier or acquisition unit. So the electrode artifacts, these are artifacts because of the change in the impedance in the electrode. whether there is a loose contact of the electrode or drying of the electrode gel can cause electrode artifacts. These are restricted to a single electrode. Any unusual waveform that is restricted to a single electrode is considered as artifactual. And most common type of non-physiological artifact is electrode artifact, manifest as a sharp, slow wave or a heterogeneous morphology and amplitude. So it consists of an electrode pop, electrode movement artifacts or perspiration or a salt bridge artifact. So electrode pop, it is the most common electrode artifact, occurs when the electrode moves, and electric double layer which forms between the electrode and the skin surface. So there is silver chloride electrode we use, and there is we will use the conductant paste. So when there will be formation of the double layer, electrical double layer with negative and positive. When there is a disruption in this electrical double layer, this might produce a electrode pop because of the change in the impedance. So it will have a sharp rise followed by a shallow fall, like an exponential decay resembling a DC potential, DC signal. So can imitate a focal spike or sharp wave, but it is limited to a single channel. It will in a bipolar channel, if we see a electrode pop, it appears like a mirror image. So it occurs due to poorly attached electrode or drying up of the conduction paste or a jelly, or any broken lead wire can also cause this electrode pop. So this is an example of an electrode pop, which we see at the C4 electrode pop. So this is forming a mirror image in bipolar montage. So when we go to the common average, the electrode pop is isolatedly present in the single channel, that is C4 electrode pop.
Sharp rise and fall. The decision.
So this is a sharp rise and fall, which is called as a DC shift.
Because it's
Exponential.
channel. That's a usual.
And it is confined to a single channel. So we are sure that it is electrode artifact, electrode pop. So these are the repeated electrode pops which are seen at the P4 electrode. So when we see it in the common average, we can see the P4 electrode pop. So single channel which is producing electrode. So electrode lose contact. Poor electrode contact causes instability in impedance and causes continuous low amplitude rhythmic activity, which may be interpreted as a focal slowing. So it is also restricted to a single electrode and can be corrected by a fixing. So this is one electrode loose contact which is showing out of phase in P3 electrode, which is corrected with the proper placement of the electrode. So when we see in the common average, we can see it is restricted to a single channel. So this is one more electrode pop, which we can see here. Salt bridge artifact. This is produced because of the smearing of the paste between two electrodes produces a salt bridge. So the EEG works on a differential amplification. So what happens is EEG activity in each electrode. So there will be a sum of the activity of two electrodes. So when the combined activity differential, we will see the differential amplification. They cancel out each other, and which results in an isoelectric line. So more common when the electrode are closely placed, like in 10-10 system, or when you try to place a 10-20 system on a neonate. So this is a salt bridge which is forming a isoelectric artifact, isoelectric line over the P3O1.
What's the channel?
P3O1s.
What does it mean?
P3 and O1 are equipotential. They are connected because of this salt bridge. Because of the formation of the salt bridge between two conductance.
That causes the
Short circuit.
actual short. Primarily the potential difference in the two channels.
So there is no potential difference between two channels, physiologically forming a short circuit between the P3 and O1. one artifact, photoelectric artifact. So this photoelectric artifact occurs during the photic stimulation because of the photochemical reaction in the electrode. This occurs when there is a high impedance electrode. So this will be a brief spike-like transient in the high impedance electrode. These are confirmed by blocking or covering the electrode will rectify this artifact. So when we give the photic stimulation, there will be formation of the photoelectric artifact, which is seen in the frontopolar region. So usually they are seen over the electrodes which are of high impedance exposed to the photic activity, so photic stimulation. But they can be seen in multiple channels. So this is a photic artifact which is seen in the channels which are exposed to the. So this is a photoelectric artifact which is seen in the channels which are exposed to the photic. So usually they are seen in the high impedance electrodes, but when there is a system reference have a high impedance, or a ground electrode is having a high reference, it can be seen in the multiple channels like this. Photic drive to be differentiated.
Those channels conventionally show. Specifically, those channels show high impedance. Right, if you get high impedance in the segment of channels, what would be the ideal impedance?
Less than 5 kilo ohms. So
What are the situations?
when we don't properly prepare the skin preparation, or there is a drying of the conductor gel, can cause a high impedance.
Say that these are the reasons why we could get high impedance that is not produced.
So the high impedance can be because of the improper skin preparation or the drying of the conductor paste. Versus the photic drive, which is also seen in the intermittent photic stimulation. This is not an artifact. So it is physiological phenomenon. So it is a physiological phenomenon. It occurs over the posterior head region. Because of the occipital lobe activity. Similar to your occipital lobe activity, visual evoked potentials, similar to that. Time locked the photic stimulation. So correction of the electrode artifact, electrode impedance should be less than 5,000 ohms. So we have to properly, surface preparation is important. Refill the electrode with jelly if high, or proper electrode application, avoid faulty contact and drying up of the gel. And rechlorination of the silver chloride electrodes, adequate skin preparation, removes surface oils, and bunching of the electrode wires behind what we do will prevent the excessive movement in the lead wires and excessive tension in that, which might affect the impedance. So check proper jack connection inside the head box and avoid smearing of the conductive paste. So all this to be taken care to avoid the electrode artifacts. So the cable artifact can be because of the movement of the input cables between the electrode jacks box and the amplifier, and can cause a capacitive coupling and a transfer of energy between the cables. So this might produce an artifact which is seen in the channels. Here we can see the cable artifact which is seen in the temporal like right temporal channels. So when we correct the cable, so this disappears. Jackbox artifacts, when electrodes are displaced from a jackbox, or when an amplifier gets disconnected, we can see. So amplifier will amplify the signals, like the signals produced are in the microvolt potential, which cannot be picked up, which cannot be read by the picked up. So the amplifier helps in the amplification. When the amplifier gets disconnected, we cannot see any potential. So it will form a straight lines. So when the electrodes are disconnected from the patient, it might pick up the environmental stimulations, whatever the noise, and it will show the rhythm, which might be when the electrodes get disconnected. So this is the environmental artifact, which is 60-50 hertz ambient electrical noise, most common external device artifact uh, because of the alternating current in the power supply. It interferes with the system. Any inadequate skin preparation leading to poor electrode contact, which will change the impedance, or defective cables, lead wires, or a faulty grounding are the various reasons why we get this artifact. And myogenic artifact is a differential. So the handy detector for a high impedance electrode during EEG recording will avoid this. And 50 hertz artifact in all channels indicates there is a problem with the ground electrode. So and should be investigated because there is a electric safety hazard. So this is a artifact which is a 50 hertz artifact because of the power supply. So when the ground electrode is checked or electrode is checked, so this gets disappeared. And when you on the notch filter also, this filters of the most of the 50-60 hertz artifact. So they have a precise band rejection capability. When turned on, it will selectively reject the 50-60 hertz frequency. So when you off the notch filter, we can see the 50 hertz artifact, which is seen in the channels. But when you on, there is a reduction in that. So electrostatic artifact due to static electricity stored on a clothing and bedding, particularly synthetic fibers can cause this electrostatic artifact discharged by touching metal bed rails or a person-to-person contact, and this appears like a high voltage spike transients, which are seen. So this is the electrostatic artifact, which so other environmental artifact, electrical activity in the vicinity like mobile phones, computers, and ventilator and IV drips in ICU settings can cause the artifacts. So the ventilator artifacts, if we go, it is produced because of the rhythmic movement and vibration within the ventilator tubing. Fluid within the ventilator circuit will oscillate with every beat. So this might mimic a burst suppression pattern, but there is a strictly periodic matching with the ventilator rate, which we should be carefully looking into. When we off the respiratory pump action, this artifact will disappear. So we can identify it. So this is the ventilator artifact, which is occurring like a burst of. Along with the ventilator artifact, we are seeing one more artifact here. So which is not time linked with the EKG artifact. This is a IV drip artifact because of the IV fluid drips, which causes also hydrostatic potentials, which are picked up by the EEG. So this this will be similar to the rate of the IV drip. This is EKG, but these artifacts.
See the artifacts coming. That's what you see the ventilator artifacts, EKG artifacts, or the artifacts. The artifacts generally have to show the EKG properly demonstrating. And I'm not coming for
Patting of a child will produce a patting artifact, which is seen here. It is a out of phase activity, which is seen in the electrodes here. So this is a patting artifact which is produced. So the artifact detection and rejection. So there are band pass filters or manual rejection of the artifact segment. Band pass filter is if analysis is restricted to certain band frequencies, this can be used.
grounding of the system, various noise. So if you have a lot of, like for example, if you have a lot of interference from the external environment, that can be a problem. Both your machine as well as the plug switch should be adequately grounded. Earthing should be good. The electrical connection. Then subsequently, you should ensure that the impedance is adequate. The impedance should be less than 5 kilo acceptable. Maximum is up to 10 kilo.
10 kilo ohms.
Generally, it should be less than 5 kilo ohms. Very low impedance also is not found in the panels and should not be less than 1 kilo. But then, are likely to get your perspiration artifacts.
Perspiration.
So that is the next step. There
Oh.
are adequate patient preparation.
Adequate patient preparation and proper electrode placement, and impedance should be within 5 kilo ohms, and proper connection into the jack box, and the steps we should take to prevent the artifacts. So the artifact rejection, there is a band pass filter, which is for example, like if you use the band pass filter of 1 to 20 hertz, which will remove the muscle artifact, but it is not very useful because it will cause the aliasing of the EEG. There is a manual rejection of the artifact segment where the technologist or EEG will review the EEG visually and marks the segments with the artifacts. And once the artifact segment is identified, this will completely eliminate that segment from the analysis, but may miss the segment of interest. And it is time consuming. The same thing which the machine does is a automatic rejection of the segments. So this can also miss the useful EEG. There is a technique called as automated subtraction of the artifact, where we only remove the artifact and we will decompose the EEG into various using the source decomposition techniques. We decompose the EEG signals into individual components, and we will remove only the artifacts and reform the rest of the EEG. So this is one of the automated subtraction of the artifact which can be.
Rejection is not there. Where a machine with adequate common mode rejection ratio more than 120 decibels to ensure that common mode signals are adequately rejected. When you're buying a machine, you can ensure that that's the adequate PFR.
So when we buy the machine also, we have to ensure that there is a adequate common mode rejection ratio of the machine. So to eliminate the common mode signals, which by the differential amplification. So recognition of the artifact is important, source identification and elimination of the artifact if possible, and avoid the misinterpretation of this artifact as a epileptiform abnormalities. This requires a skill and experience technologist and EEG interpreter. If there is a confusion like we saw in a tremor artifact, we can clarify with the video if available. If there is any doubt whether to go for a conservative interpretation, and repeat EEG if there is any EEG clinical conflict. Thank you.
You know your artifacts, you know your EEG, more than the know your artifacts. Otherwise, you can overinterpret the. Generally, you have to recognize what is the ideal approach when you are seeing any transient and asking the question whether it is an artifact or whether it is a anomaly. The first question is obviously, is it a physiological transient? If it's not a physiological transient, then whether it is an artifact or the artifact is the benign agent. The last question is whether it is differently impacted. Of course, when you see certain morphology fields, you recognize that these are elliptiform and abnormalities, so you classify further as fine, sharp objects, periodic studies, or so transients, whatever. Generally, if you see a potential without a field and complete a very monomorphic pattern, then more potentials with a very complex field, repeating at a specific frequency, more the record would think that these would be artifactual anomalies. So recognizing artifacts is very important. We don't with your technologies, the setting up an EEG system, the technologies. Have discussions with them.
Thank you. This is the end of the presentation.